Hey everyone, welcome back to The Checkup, CMH's new podcast. I'm super excited to have with me today Dr. Brissy, our foot and ankle surgeon. Welcome to the podcast. We're excited to have you on.
Thank you. It's nice to be here.
Yeah. So we were kind of chatting before we started recording about vacation coming up, and I am looking forward to spending some time on the beach this summer and doing some sightseeing. So my first question, and this is completely selfish, is what should I be looking for in a shoe to take with me on vacation so that I don't hurt my feet while I'm walking around?
Well, if you have room for it, probably first and foremost is you should have a couple different pairs of shoes, because worst case scenario, you have the shoe that you think is the best and it's uncomfortable. And now you don't have a shoe. Now you got to go shopping, which some people would like, of course, right?
I would.
But yeah. So I'd probably take a couple different pairs if you have room for it, 2 to 3. Something supportive if you're going to be doing hiking on the beach. Those water shoes and flip-flops are probably okay, but barefoot on a beach is probably how I would do it most of the time. Not necessarily the safe answer, I guess, because I guess there could be glass or rocks or shells or whatever. But I would say the best way to determine if a shoe is going to be good for you, whether you're going on a vacation or you're buying a new shoe in a store, is to put the shoe on, make sure it fits. One of the best ways to determine if a shoe fits properly is to go to a good shoe store. Most good shoe stores, I'll say, quote, good shoe stores will have like what's called a Brannock device, and their sales representatives will have some knowledge in how to actually size a foot, because a foot is not, we say, oh, my foot is this long or whatever, I'm a size 8 or 9 or whatever, but the ball to the toes matters, the width of the forefoot matters, the heel to the ball matters. So to get properly sized is probably the most important factor if you're looking to find the right shoe, because the right shoe size is probably the most important thing. After that, I would say it is quite variable. Like the shoe, the New Balance 928 that might work for one person and they swear by might be, the next person might say they hate, and Asics for one person might be hated by the next person, and so on. So when I buy a shoe, what I'll do is if I have shoe inserts, I'll take them with me to put into the shoe to try on in the store, because if you have an insert that you like or that was custom made for you, if it doesn't fit in your shoe, that might be kind of a bummer for you. But I would take the inserts, number 1, if you have them. Number 2, if you don't, I would take my time walking around the store with the shoe on. The shoes on, you should lace them up. And most people that sell in stores would advise you to do this as well, but you should lace them up, walk around. Number 3, when you get home, is you should walk around the house. If in the store it's not comfortable, it's not going to be comfortable when you get home. It's not going to be comfortable when you're outside. If you think it's comfortable in the store, you don't have the hour to walk around in it or half hour to walk around to determine if it's adequately comfortable for you. You may have that opportunity at home. And if you get home and you wear it in the house to see if it fits and it doesn't, you can potentially return it. But if you wear it outside and get it dirty, it's a little bit harder to return a shoe. So that's kind of the general, maybe very obvious answer to what a good shoe is. But yeah, I would try it on. I'd wear it in the store. I'd wear it at home, walk around, and then, and now when you talk about the fit of the shoe, you wanted to feel that shoe in as much of your foot as possible. Generally speaking, if you have a very flat foot, you're gonna feel your arch in the shoe kind of no matter what. If you have a high arch, you may not. But so you want to find a shoe that hits the more surface area of the bottom of your foot as possible. So
most of your bottom of your foot should be touching the shoe as much as possible.
As much as possible, because if you think of the foot like a tripod, which it's not, but if you think of it like, a heel as being one part of the tripod, and then the other two portions or the forefoot as being the other two parts of the tripod, you are having weight on those 3 spots, and that's your whole entire body weight on a small surface area. If you can distribute the weight more evenly over a larger surface area, you're going to have less pressure in those individual areas. So that can be an answer to, especially for people having heel and forefoot pain, is to get more weight into the arch. So arch supports do that too. But
I've never heard that. That's really
yeah,
interesting.
yeah, the more the shoe fits the arch or the whole entire foot, generally speaking, the better it is for you.
And that really kind of explains why I love one kind of shoe and my kids like a different kind or whatever, because everybody's built differently. So my kids give me a hard time about this a lot because I don't wear socks all the time. Is that bad? Is that a terrible habit I should break?
Yeah, it's bad.
Yeah, I was. I was afraid you were going to say that. So
No,
tell
I mean, no, it's not that. It's not that bad. I mean, barefoot walking in moderation for the right person is good. Barefoot walking or minimalistic walking for the right person all the time can be good. But generally speaking, for Americans, we may be, or people who may be carrying a little extra weight, support is good. And we're back to socks. Socks are going to keep your foot like more. They're going to reduce friction and shear, which can lead to blistering. And another thing that happens when people don't wear socks as much is they'll tend to dry out and fissure and develop cracks and dry skin. Yeah. So socks help maintain moisture a little better. Obviously, in the winter, they keep you warmer than the shoe alone.
That's true. What about, is it better necessarily to drop a couple $100 on a pair of shoes? Are expensive shoes always better? I guess is what I'm trying to ask.
Yeah. No. Here's something I tell all my patients. When I first moved to Robinson about a year ago, I did a little experiment. I went to Walmart and I bought 5 pairs of $20 shoes. And then for about that year, I've been here a little over a year, but for about a year, I pretty much wore those shoes all the time. And a good pair of inserts can make a very bad shoe a lot better. So I wore my custom inserts inside the $20 shoe and had absolutely no problems.
Really?
And, they were man-made materials, not leather or whatever. So they might not breathe as well. But as far as support goes, the Walmart shoe with a good insole is probably a lot of times better than the like $150 pair of Hokas without a custom insole in it. If the insole's made correctly.
Huh. That's pretty interesting.
Yeah. But to answer your question, generally you get what you pay for.
Yeah.
Generally. But there are some hacks.
And that's something that you could do. Like if they wanted to come and talk to you about insoles or orthotics or something, that's something that you can do here.
Yeah.
Work with them on.
We order those and get those made for
Do you
people.
recommend those for a lot of people? Like, that's something everybody should be doing?
I think everybody should have a pair of custom insoles and one or two pairs. I mean, this is kind of like in this ideal world where we have an infinite amount of money and can get everything we want. Should have a couple pairs of over-the-counter insoles and probably a pair of custom insoles. Yeah.
Just because it makes like we were talking about earlier about the amount of foot touching the shoe, just to kind of improve that, right? Is that true?
Generally speaking, the insole does that. It increases the surface area that's supporting the body. So if an over-the-counter insole can support the body just as well as a custom in some cases. There's few conditions where there's some studies that show that over-the-counter insoles are as good for certain conditions. Generally speaking, a well-made custom insert is going to be better for everybody than an over-the-counter.
Individualized, right?
But you might find that over-the-counter insole that just was made for you.
Yeah.
Right?
Yeah.
It matches your foot perfectly.
Might get lucky.
Yeah. There's so many different kinds these days. So you have medium, low, high, medium, high, ultra high arch. So
That's probably just trial and error again, just to see what feels comfortable.
yeah. And actually I have a good example of one company with me. I'm not a company that I necessarily recommend, but Superfeet is a good example of an insole. I don't know which camera I'm looking at, but Superfeet is a good example that makes varying arch heights. So this is an over-the-counter insole, and I tend to get my insoles at I'm a bit of a cheapskate. I get them at Marshalls, Ross, TJ Maxx.
Like TJ, yeah.
Because you just find, the $50 insole for $5 or whatever. So anyway, Superfeet this is probably like a medium arch. I'm not entirely sure it's a size B, but anyway, One example. And so what you could do, let's say you went to, so Dick's Sporting Goods is one store that carries Superfeet. There are many other stores that carry them. You went to a store and you found a few different sizes. Is you could pull the one out, see how it matches your foot, right? The more you feel it in your foot, generally speaking, the better. Now, if the bottom of your foot hurts and you're putting more pressure in that area, like if the arch hurts and you're putting more pressure in that area, you could cause some more discomfort. You could cause problems, but that's kind of a generality. Doesn't fit for every person.
I'm gonna come back to that, but I mean, how do I know if I have a high arch or a flat arch or a medium, or I mean, is there a way to tell?
Probably not looking at it yourself. I mean, I get a lot of patients who come in and say, "Oh, I have a flat foot," and they have, on average, if you measure the average person, they have a higher arch. And I have people who say that they have a high arch, and if you measure the average person, they have a flat foot. So it's not really easy to tell for you looking at your own foot, but there's a good variety.
So you talked a little bit about pain. You just mentioned that. So at what point do I need to come see you? Like, let's say at what point do I need to say, okay, this is more than just my feet hurt at the end of the day?
Sure.
How do I know when it's time to come see a doctor?
If your feet start hurting and it's not really affecting what you're doing, it's bothering you but not affecting what you're doing, and it goes on for a week or two and it's getting better, or it's just getting better, there's probably not a reason to be seen for it. But if you're progressively getting worse and worse, if it's affecting what you do, like you can't do the things you want to do or need to do, those are situations where you should be evaluated, even if it's only been a couple of weeks. Sometimes catching things early is a lot, is beneficial or quite beneficial. And sometimes it's kind of too early to catch certain things. But yeah, the general answer would be, if it's affecting your ability to do your job, to do the things you enjoy, if you were a walker who can't walk anymore, and you're noticing that something has come on and it's getting worse, be seen. If there's swelling, redness, that kind of stuff, it should probably be evaluated. If you have diabetes or neuropathy and you have an ulcer or wound developing, it should probably be evaluated by a wound center, primary care, foot provider. If you've had an injury and you can't bear weight on it, it needs to be evaluated. That probably goes without saying. But there are some people who just use crutches and think that in a few days they'll be able to put weight on it. If you can't put weight on it after an injury, you should have it evaluated. Yeah, that's
what. So I think sometimes people hear podiatry too, and they think, oh, it's just like my heel pain. But you do a lot more than talk a little bit about all the different things that people might come to see you for.
Actually, so today's podiatrist there's a good variety of podiatry and podiatrists and podiatric surgeons. My emphasis is mostly in surgical reconstruction. My career's been primarily that, from training through my entire career. And the things that people see me for would be chronic conditions. Mom had a bunion, and that was fixed, and maybe she didn't fix the other side and wish she did, and now I'm developing a bunion and I think I want to get fixed. Something's been hurting for a while. It may not be to the point where it's stopping you, but you're constantly thinking about it. You come in, so bunions, hammer toes are things that I treat, surgical and non-surgical. Hammer toe surgery can be done very easily. It can be done with you awake. It can be done without sutures, via a no incision technique. But and there aren't many procedures like that, but that one in particular is a high yield, because hammer toes, once they start, generally get worse and worse and worse. And so as a hammer toe progresses, the joints become ankylosed, start to get arthritis. And if you get it early, you start to notice one of your toes is contracting early, you can release a tendon, lengthen a tendon easily, percutaneously, and solve a problem that's going to happen in the future. But I think your question was, what do I do? So I do everything from my area that I've been interested in has been reconstructive surgery, which includes acute traumatic injuries, lawnmower injuries, motor vehicle accidents. I've had demolition derby accidents, falls downstairs, falls off ladders, falls off of houses, out of trees. So the more traumatic, and then which is like urgent, needs to be done now, or can be done within like a week or two, to infection and I'll say the person with diabetes, but it isn't just diabetes. What happens is people can get neuropathy, they can't feel their feet. That can lead to sore spots that they don't know. Those sore spots can get infected. So surgical offloading of a person like that, they say they have a hammer toe is a good example. If you can't feel the tip of your toe and you have a hammer toe and it's rubbing in the shoe and it gets a sore spot or it gets a red spot, and all you need to do is nip it with a fairly, maybe not that simple, but a fairly simple procedure in the office to prevent that from becoming an infected toe that's very high yield. So diabetic / people with diabetes, their reconstruction of the neuropathic foot is another area that I like, that I have a lot of interest in. Minimally invasive surgery. So in all areas in orthopedic surgery, there's been a push over time to do things through smaller and smaller incisions. So at one point, they transitioned to using arthroscopy, and arthroscopy was initially looking through a tube, like actually looking through a tube, and now there's cameras and screens. But doing things arthroscopically, doing things percutaneously with burrs, kind of like dentists use. So small incision stuff to reconstruct the foot is another area. So the traumatic, the reconstruction of the deformed or malformed foot. So children with who are born with unusual foot conditions and maybe don't get them corrected, and it progresses, that can be needed. Adults can develop problems. Flat foot, high arch foot. I deal with arthritis in the ankle. That could be anything from a scope to clean it out. It could be a ankle replacement. It could be an ankle fusion, depending on the age and patient's desires.
You don't hear about ankle replacement much.
Yeah.
It's really neat.
Yeah.
Fascinating.
Yeah. Ankle replacement is probably one of the least replaced joints, but is becoming the standard for ankle arthritis. Like once upon a time, maybe 10, 15 years ago, if you asked 9 out of 10 reconstructive foot and ankle surgeons, they would say, maybe even a little bit further back, they'd say ankle fusion. But now it's switching, and the ankle replacement is being used more and more, and even in younger patients. But
so fusion is, sorry to interrupt you, but fusions were like they fuse your bones together, right?
Yeah.
So that they don't rub or cause that.
Yeah. So if the arthritis is causing the joint to swell and then be inflamed and painful, then you take the motion away, but to get rid of the pain, you make two bones into one, essentially. So if I can use my finger, if this joint right here, and it's not commonly done in the hands, but if this joint is hurting, and I can move this joint, and all I need to do to make my hand pain go away is fuse this joint. That's in the foot, right? That's kind of like what we'll do sometimes. Ankle is similar. With the ankle, you don't, because of the way the foot is with the 28 bones and the way it moves, you can fuse an ankle and still have quite a bit of motion in the hind foot, enough to walk, but get rid of ankle pain. So fusion is kind of like essentially joining two bones together to get rid of the pain and inflammation in a joint that's irritated. So yeah, so that was the traumatic injury, the infection, and the diabetic reconstruction, the deformity correction, bunions, hammer toes, flat foot, high arch foot, lower leg angular deformities, and everything in between. Yeah. It's what I like to do.
I would say you can tell you love it, that you're really passionate about it. What made you decide this is what you wanted to do? Why did you pick this field of medicine?
Wow. That's kind of like I threw a dart at a dartboard. No, it's kind of like it's a long question, because originally I didn't grow up, with goals of going into healthcare in any way. I joined the Army in my early 20s, and learned Chinese, spent time in China and flew back and forth, and then left and started a business with my wife. And at the time I had my educational background was in economics and Chinese, and we decided to import from China. So I imported turquoise, jade, furniture, clothing, cultural items, tea. They call them tea boats, but they're little tea ceremony cups and trays, and I had GI Bill money to go back to school, and I was like, I want to kind of I will consider myself a lifelong learner, so I'm always trying to learn new things, and I was like, well, what do I want to do next? And it wasn't that I was necessarily looking for another career, but I thought for a while, and I was like, what is kind of recession proof, at least over the next 10, 20 years? What is going to be something that's in need? What do people need? And I kind of stumbled upon healthcare because I was like, should I go back in the military? I had a good career, a good time in the military. Most of my colleagues stayed in the military, and then did more after their initial 5-year term or whatever. But so I was looking online, and I saw that the Navy had a posting for a dental surgeon, I don't know, and that got me thinking. And I was like, oh, I like working with my hands. I like working with like wood and building things. And when I was a kid, I always wanted to be an inventor, whatever that means. But I wanted to be an inventor, and I would just take like rolls, paper towel rolls, and this and that, and make things and make messes in the house. It'd often get in trouble. But then it got older, and it branched out to woods and more durable inventions. But anyway, so I'm like thinking, and I'm about the dental position. I'm like, that would be cool. It's needed. Dentistry is needed. I had my own dental problems, and so I went and spoke with a counselor, and I knew healthcare at that point. I was like, okay, healthcare would be a good option, and I didn't know much about what was available in healthcare, and I was like 24 at the time. I went to speak to a counselor at the local college, and she started talking about different healthcare careers, which were like dental surgery, hands-on, good, well, relatively good home life or time away from work. Right. It wasn't like at work all the time, even though that has happened in my career, but not here.
That's what I like here.
And so she told me about many fields, the allopathic and MD and DO routes to the different specialties that are hands-on. We talked a little more about dentistry, MD to dentist or dental surgeon, dental surgeon or DDS to dental surgeon, or we talked about optometry. That wasn't as hands-on as I would have liked, and but it was something I thought about. And then I happened on to like podiatry, and then I recalled when I was in my in my infancy in the military, I had a foot problem, and I was in San Angelo, Texas, and I was sent to a physical therapist, and they made inserts for me, and I would recall those inserts worked quite well. And then I was like, well, so then I looked at physical therapy, but that kind of led me to podiatry. Initially, I was like, nah, it's not hands-on enough, or it's too simple. And in all honesty, the foot is extremely complex, 28 bones. I mean, you have to walk every step, thousands of steps a day on it, so it has to maintain its integrity. But so initially, no. But then I looked into it further. I shadowed dental surgeons, and at one point, I kind of nailed it down to dental surgery and podiatric surgeon. And so I was doing, even before that, since I knew I wanted to go into healthcare, we were doing the store, I was selling online, raising our first child together, and where am I going with this? Oh, I was doing my prerequisites, and I'm like a year into prerequisites. I have no science background, mind you. It's all economics and math and stuff, but no organic chemistry, no inorganic chemistry, no, a little bit of physics, but not much physics, no biology, no anatomy, and And so I was taking those courses, which were definitely prerequisites, whether you were going to become an MD, a DO, a DPM, a physical therapist, whatever. And she told me like a year in that you can apply to podiatry school. And at that point, I had just shadowed a few more surgically oriented podiatric surgeons, and I was like, they are like the guy I shadowed was in surgery like I think 3 days a week, sometimes 2 days a week, and then took some call. So at that moment I was like, oh, I guess I might as well apply, right? Like, what's going to hurt to apply? Mm-hmm. And I applied and got in and was like, do I want to do this? Do I want to like continue prerequisites to do like the MD route or the O route? And I was like, so then I asked a few people. I asked more podiatrists and on the surgical side, because I wanted to be more hands-on, more, not that you're not hands-on in the clinic, but more surgically oriented.
Sure.
And
more like the building.
they were saying like the field is growing, it's constantly growing. And I said, okay, I'm going to do it. And I never looked back. I started immediately. I was enjoying it. I went to school with MDs. We took a lot of all the same classes. We had more of so when it came to anatomy, I dissected the whole body, but then I had a second dissection of the hip down, and I had to know everything. Like, there was nothing I couldn't not know. Mm-hmm. Yeah. So then so that was interesting. And then we did all the pharmacology and all that kind of stuff. And school was great. I did my clerkships and all that, went around the United States doing different surgical rotations, and rotated in many areas, and ended up in Rockford. But anyway, the long story short was that why did I choose podiatry?
Yeah. Got there. Yeah. I mean, that's fascinating though. It's such a neat...
I've been happy the whole while. I think I've been fortunate because there wasn't a ton of thought put into it. I do overanalyze things, but I don't ever come to a conclusion. So often, in that case, the same, but it ended up ruling out other things. Yeah. And I went with it kind of a little bit on a whim, but I've been really, really ecstatic because the majority of my career has been, there were 6 or 7 years in a row where I was on any given day, I was in surgery probably half the days of the week, 3 to 4 days a week. So I was very, very busy doing the things I liked, and I got to be inventive. I've invented surgeries and I've invented procedures. Yeah. So it's, I'm glad I decided to do it.
Good.
Yeah.
So you've invented surgeries? That's really, like what? Like, that's really neat.
Well, invented surgery is like most things that exist have been done in some iteration, in some way. But so one in particular, there's something called a Haglund's deformity. Here, I'll use one of the things I've got here. There's something called a Haglund's deformity where the back of the heel starts to get bigger because the Achilles is irritated. Okay. People get a spur in the back, and they get sore in the back, and they have tendonitis, and the recovery is very long. So, a quick recovery would be 12 weeks. An average recovery would be about 6 months, and potentially, it's a year before you're actually even really feeling somewhat normal. Now, you can walk after 8 weeks, but you're just hobbling along. So you have a lot of hobbling. Anyway, so I was like, well, how do I make that less morbid? How do I decrease morbidity on that surgery while still solving the problem? And so explored, and this is done too, minimal, less invasive approaches where you use a scope instead of opening. Oh, so let me get back to how that's done. You have an incision along the back. The skin is open. The Achilles is detached from the heel bone. The heel bone is cut across the back of it like that, and then anchors are placed into the bring the Achilles back down. So you remove all that bone off there, detaching it, reattaching it. It's very painful. So I was like, how can I make that less morbid while still achieving good results? Maybe not, you're not aiming for 100% symptom resolution, but if the people don't think about it, if you're 10% better, or if you're
90% better.
Yeah, 90% better, and you're doing everything you want to do and you barely notice it, but every once in a while, it's probably, I would call a success if it's going to save you months of recovery, right? So I had a patient who came in. He was a truck driver, and he would jump in and out of trucks and was getting tendonitis back there and his pain fell back there. And granted, in his case, although there was pain here, it was more radiating up the Achilles. So he said, what can you do, doc? I said, well, I can't really inject your Achilles with a steroid because it really puts you at risk of rupture. And I've seen that happen before. Patients sent to me with a ruptured Achilles because it was injected with steroid. But theoretically, if I stimulate it, I might cause an acute inflammatory response and help your body to heal itself. And so what I did was, in his case, I numbed him up. I took saline and a large gauge needle, and in the office, and this wasn't comfortable for him, but in the office, I poked about 20 holes into the Achilles and hydrodissected very minute amounts of the sterile saline, injectable saline. I had him in a boot for 2 to 3 weeks. I said he could do whatever he wanted in the boot, and then came back in 3 weeks, and he told me, I feel 50% better. I can get in and out of the truck without problems. And so then from there, I was like, well, what else can I do to help this condition? And it is known that if you decrease the tension on the Achilles, it will take some of the pain out of there potentially in the right patient. So there's something called a gastroc where you, through a camera, you lengthen the muscle above. So I added that. I added the lengthening of the muscle. And then I started using withdrawing bone marrow, mixing that with stem cells. Mm-hmm. Patients spun down blood, which is called platelet-rich plasma, or bone marrow aspirate concentrate, and made a solution that would, on top of causing an inflammatory response just from the mechanical stimulation of the needle, it would actually cause a biological response. And so I didn't even name the procedure, but basically it can be about a 30-minute procedure. And that's more waiting for the blood to spin down and stuff like that. Mm-hmm. But it's two stitches in the leg and nothing else, for a surgery that generally had you wide open and on the couch for months. And this particular procedure, you're walking right away with a boot on, and then within like 3 to 4 weeks, you're easing out of the boot. And it probably saved half of my patients from a larger procedure.
Sure.
Every once in a while, someone has that procedure done. It gets them better, but not as better as they want, mm-hmm. and they go on to a bigger procedure. But I'd say that the numbers, if it were me, and I could try the lesser invasive procedure, I would do it almost every single time.
I would for sure. That'd be a lot less. Yeah.
I mean, this is a good procedure. Success rates are very high on that one, but the morbidity, the mm-hmm. length and pain and all that is intense, and the time is long. Yeah.
Huh. That's amazing.
So that's one. And then I've done a lot of other things in residency while I was in surgical training. Yeah. I made some cut guides for doing like more percutaneous stuff. Huh. And
that's fascinating. It's really neat. So if there's one thing, because I think we're probably about ready to wrap up here,
sure.
but there's one thing that you wanted everybody to know about their feet.
Yeah.
What would that be?
All of our feet are some point going to hurt. If you have foot pain, that's temporary and goes away. That's very normal. But foot pain that persists and doesn't go away is almost never normal. And most of the time there's a solution. So if that's the case, get checked out. I guess that's one very important thing that I would tell everybody. Yeah. And then feet are important, often neglected, not thought about much. You throw them in the shoe and get on with your day, but you do think about them when they start hurting. And so most of the time, if something's hurting long enough, people will get seen. So I would say in addition to that is sometimes people wait too long to be seen. So if it's getting worse, ideally you shouldn't wait too long to be seen.
And they don't need a referral to come see you. They can just call, right? Make an appointment.
Yeah, absolutely. No referrals necessary. I mean, not that I know. There may be some insurances that have
right, but for the most part.
But no, I think 95 to 99% of people do not need a referral to come see you.
And we'll put your phone number in the show notes so everybody has that too.
Sure.
So, all right. Well, thank you so much. I know you're busy today, so thanks for taking some time out to come chat with us. We appreciate it. And I wrote down the name of the insoles, so I'll check those out too.
All right.
So, all right. Thanks. Thanks so much.
You're welcome. Thank you.